I will officially start on it, and I request Mr. Chuchi from the FARO Secretariat, please run on the address of our president from FARO president, who is not available lively at this point in time. We have his video recorded message, and he will display on that.
Dear friends and colleagues of FARO, welcome to 20th FARO webinar. I am Xianshu GAO, the president of FARO. It is my great pleasure to give an opening address to all of you. FARO started webinars in 2020 as a result of the pandemic of COVID-19. I would like to recognize the hard work of all the FARO officers and members, especially the Education and Training Committee. This webinar is organized by PSCO, AROS, and ARORA. Thank you very much. We are looking forward to more cooperation around FARO members in future. Radiotherapy plays an important role in the treatment of the head and neck cancer. I hope all the participants will get useful information and valuable experience to today's webinar. Please enjoy the webinar. Thank you.
Thank you very much. Now I will request to Professor Dr. Mohammad Faheem, President, Pakistan Society of Clinical Oncology, for welcome address. Please.
Thank you, Dr. Azhar. Assalamu alaikum and very good afternoon. I'm really thankful to FARO, especially the President, Professor Gao, and the officers, and especially Professor Tati, Professor Dakata, Sushi. And now I can see the Vice President of FARO as well, Vashitra, and my team. I think this will be a very wonderful webinar, because we have selected this very important topic, which we normally come across in our daily practice, especially those who are treating head and neck cancer. Peri Neural Invasion, we take it as a poor prognostic factor whenever you see the pathology. And whenever we see the Peri Neural Invasion in head and neck cancer, so contouring is and very important thing which we have to do whenever we see the perineural invasion. So this will be, I've got a very good team who will be presenting this topic here, and panel of experts you can see on your screen. They are the masters of this specialty, and I think it will be a wonderful webinar. I wish you all a great day today. It will be a 1 hour. 1 hour is not enough to cover this important topic, but we will try to cover it, and hope you will learn something, and I myself will be learning something new as well. Thanks a lot. Thank you very much.
Thank you very much, Professor Dr. Mohammad Faheem. Before starting our talks today, I would like to introduce myself and our speakers and our panelists. I am Dr. Azhar Rashid from Karachi, Pakistan. I am CME coordinator, Pakistan Society of Clinical Oncology, and currently I'm working as clinical radiation oncologist in Karachi Center, which is known as a Pakistan Gamma Knife Center as well. And in our team of the panelists, we have Professor Dr. Humaira Faheem from Pakistan. She is currently working as a consultant clinical and radiation oncologist, and she is chairing and heading the oncology department at Noori Hospital, Islamabad. And along with her, we have all the ladies panel today is a chance. And we have Dr. Dini Indriani. She is consultant radiation oncologist from Indonesia. She's working in Mohammad Hussain Hospital, Plumberg. And along with her, our other two colleagues from Mongolia and New Zealand, Dr. Anerjergal, she belongs to Mongolia. She is radiation oncologist and working in National Cancer Center. Along with her, Dr. Lyndall Kelly. She is a very sweet lady and has been visiting Pakistan already with us. And she is currently working as fellow in radiation oncology. She's very senior fellow in radiation oncologist, and she stays in Dunedin, New Zealand at this point in time. So coming towards our speakers, our first speaker is Dr. Sameed Hussain. He's currently working as consultant radiation oncologist in Combined Military Hospital, Lahore, Pakistan. And the other speaker is Dr. Zeeshan Ahmed Alvi. He is consultant radiation oncologist in Combined Military Hospital, Rawalpindi. These two colleagues, they are treating regularly head and neck cancer here. And we do have this chance to get some insights on Peri Neural Invasion, pearls and pitfalls of contouring. So I would like to invite Dr. Sameed Hussain to start with his presentation on the contouring, please.
Good afternoon, everybody. Good evening. I hope we have different time zones, and after that, it would be good night to some of you, especially those who are in New Zealand. Thank you, FARO, and thank you, PSCO, for this opportunity to speak on this very difficult topic. I would start with one terminology called agoraphobia. Agoraphobia is a terminology used for fear of pathways. In head and neck cancer and base of skull tumor, it's all about pathways. If you know your neuronal pathways, things would be very easy for you. And if you don't know the pathways, you will always struggle with your contouring. So today we are going to clear this agoraphobia from the minds of few of our younger colleagues. And the sequence of this presentation, there would be no formal presentation. I would be using this variant platform for contouring and showing you the relevant 3D anatomy of the base of skull. So initially I'll talk a little about the nasopharyngeal tumors and the pterygopalatine fossa, and then we'll move on to base of skull arrangement, the arrangement of the foraminals, and then the 7th cranial nerve, and finally the very important 5th cranial nerve. I think the time would not permit all this, but we'll see how far we can go. So I have pre-drawn a simple contour, the intermediate risk CTV for our nasopharyngeal carcinomas. It looks something like this. There might be some variations, but we need to know the reason why does it look like this. Especially many of our junior colleagues say that it doesn't invade the maxillary sinus. Yes, nasopharyngeal carcinomas don't invade maxillary sinus and nasal cavity, but still we take this anterior 1/3 or at least 5 millimeter of the nasal cavity and maxillary sinus just to include the pterygopalatine fossa. So this is the pterygopalatine fossa. It lies between the maxillary bone and the sphenoid bone. This is a very important landmark in base of skull. This can be truly called the time square of base of skull because all the pathways emanate from this place and the nerves go out to different places. So just remember, if you know the pterygopalatine fossa, things would be easy for you. There are at least 7 pathways, or some might even say that there are 8 pathways which emanate from the base, from the pterygopalatine fossa. So I will move my cursor to this pterygopalatine fossa so that we can see it in all 3 planes. First of all, the inferior pathway. So the cursor is here. What I'll do is I will take the sagittal section, and you can see that there is a pathway moving inferiorly. And these are the palatine nerves which pass through greater and lesser palatine canal and finally go out through the lesser and greater palatine foramina. If I just keep on scrolling down, you can see the pathway is going. Now it's inside the bone, and now you can see a small foramina on either side. I'll move the cursor aside. And this is a small foramina which is opening into the hard palate, and palatine nerves pass through this channel. Palatine nerves are a branch of maxillary division of trigeminal nerves. Here on, I'll mention it as V2 in the interest of time. Again, I'll go to the pterygomaxillary pterygopalatine fossa, and you can see on this sagittal section, it is in superiorly, it is opening into the inferior orbital fissure and communicating branches between the V2 and V1, that is the ophthalmic division, pass through this region. The third is the pterygomaxillary fissure, the third opening, the lateral one. It opens into the pterygopalatine fossa, and the communicating branches between V2 and V3 pass through this space. This is a very small square, a very small roundabout from where all the nerves are emanating. Medially, there are two connections. One is anterior-medial into the nasal cavity, and the other one is the palato-vaginal canal, which takes the, or the pharyngeal canal, which communicates the pharyngeal nerves into the nasopharynx. So we have done the inferior, superior, lateral, two medial. There are two left. There are three left. One is the anterior one, which is the anterior one is the inferior orbital fissure, and then finally the infraorbital foramen. The main branch of the maxillary nerve passes through this and opens into the inferior infraorbital foramen. The most important ones are the posterior communications. If you can see, there is a communication posteriorly, this one. So this is the Vidian Canal, through which the facial nerve passes. One of the Vidian nerve passes, which is one of the branch of the facial nerve. If I take you to the coronal section, so you can see this small foramen, this one here and this one right here. And if I just move this, you would be able to see now two foramens here. So this one is the Vidian Canal, and this one is the foramen rotundum. What mistake we normally do is we think that foramen rotundum is a vertical passage through the base of skull. No, it is not. It is a horizontal tube-like passage, both the Vidian Canal and the foramen rotundum. This is foramen rotundum, through which the maxillary division, that is V2, passes from the middle cranial fossa into the pterygopalatine fossa. And if I just move the slices inferiorly, we would be able to see this Vidian Canal. So superiorly lies the foramen rotundum, opening into the middle cranial fossa on either side, and inferiorly is the Vidian Canal. So I will just stop description of pterygopalatine fossa here. Now we know some of our pathways and switch on the intermediate risk CTV. So we draw our intermediate risk CTV of nasopharynx to include the foramen ovale, carotid canal, the clivus. These things are to be included. So, but we need to know the arrangement. As a student, I was also struggling with different structures. The most important one is landmark is the carotid canal. You can see the carotid canal, carotid artery entering into the base of skull, and then it moves anterior-medially on either sides. Very beautifully shown on this CT scan, may not be visible on other scans, especially this scan is a 1 millimeter slice thickness scan. So things are pretty much visible here. On 3 millimeters, it becomes very difficult. So on lateral side of this carotid canal, you can see another small, very subtle opening. This one is the Vidian Canal, which we have seen before. This is the Vidian Canal, and as it passes posteriorly, it moves lateral to the carotid canal, and then finally enters the internal ear complex. Will not go into the details of that. On both sides, you can see this subtle opening, the Vidian Canal. Okay, so on the lateral side of this Vidian Canal is this oval shaped structure. This is foramen ovale. You can see on this side, the foramen ovale, and a very small spine or a very small opening. This is called foramen spinosum. If you just see this complex, you can see that this is like an imprint of heel of a female. And this is the sole of the anterior portion of the heel, an oval portion, and this is an impression of the spine. So this is like a female standing on the base of skull. Just don't use your imagination there. It's just a way of remembering this arrangement. It never changes. It is the same in 99% of base of skull. There might be some variations around. I have not seen one in my career yet. So just remember this arrangement: the foramen ovale, foramen spinosum, Vidian Canal, and then the medial most is the carotid canal. From here onwards, I would be talking about the individual nerves, especially the ischial nerve, and then I'll move on to the trigeminal nerve, and we'll talk about the foramen ovale more in detail. So first of all, the facial nerve. The facial nerve, I will also contour the CTV of the facial nerve. The facial nerve, whenever needs to be included in adenoid cystic carcinomas or other cancers of parotid gland where there is significant perineural invasion. So how do we locate it? It passes or exits the skull through the stylomastoid foramen, and stylomastoid, as the name suggests, is in between the styloid process and the mastoid air cells. So as I move superiorly now, you can see that there is a small, I will change this to the bony window. Okay, so what I'll do is I'll take the cursor at this level so that things become more clear. What I do in my practice is I locate this canal on the sagittal section. So this is the styloid process. This is the mastoid air cells, and in between this, you can see a pathway. This is the pathway of facial nerve. And if you just take the cursor to the topmost slice, you would be knowing that this small area this is your facial nerve. And if you need to contour it, you don't need to be miser with it. You can take a larger area. There is no point in just taking the foramina. You have to take this complex. The ear might not, the hearing might not be saved. So when it comes down to this region, I'll again decrease the size. This area would be automatically included in your CTV, primary CTV. It's just a matter of around 0.5 to 1 centimeter where you need to take this inside your CTV, because your primary CTV would pass through anteriorly to the mastoid air cells. As I move inferiorly, I'll include this area. And then you can interpolate this to have your CTV. There are different levels. You can contour it up to the internal acoustic meatus. I'll not go into the details of that in the interest of time, and it depends on the extent, and we would be learning about that in our next lecture. So I'll just stop it here. And we will be now talking about the most important nerve when it comes to perineural invasion. This is the trigeminal nerve. So trigeminal nerve has got 3 branches. We all know that: the ophthalmic division, V1, V2, and V3. We'll simply call that. So V1 is covered when there are squamous cell carcinomas of the forehead and the scalp. And what we normally do for contouring is that you palpate your supraorbital foramen, the supraorbital foramen of the patient, and then place a lead marker, a very small bead-like lead marker there, so that it is visible on the scan. It is very clearly visible on this patient, but it is not always this clear on all the cases. So you need to mark it before the CT simulation scan is done. This whole area might be included in your primary CTV. So I'm just thinking that this whole area would be included automatically in your CTV. Once again, you don't need to be miser. You just don't need to contour your foramen. By the way, this foramen is the supraorbital foramen, and medial to it would be supratrochlear foramen. So if you need to know what nerve you are contouring. Normally, both nerves need to be contoured simultaneously because it is very difficult to locate them separately. So moving inferiorly, you can take this whole area. This is around 1 centimeter cube or 1 cc in diameter. If I take the cursor on this, I would advise you to follow the sagittal sections as well. You can see the orbit there. We are above the orbit. We are in the supraorbital space because this nerve runs along the superior rectus muscle. You cannot localize the nerve separately, so you have to be generous in these areas. And then as soon as the orbit appears, orbit appears, you have to pass posteriorly and then just continue on tracing the superior rectus muscle. And as the nerve exits through the superior orbital fissure, you have to be careful. The superior orbital fissure is an opening which runs from medial. I'm right on the superior orbital fissure, medial to lateral, and medial to it is the optic canal. So you do not need to contour the optic canal. You just have to be vigilant of the superior orbital fissure and just contour the structures around this. So we know that the ophthalmic division will then enter into the middle cranial fossa, the cavernous sinus, which lies on either side of the pituitary gland and the sphenoid sinus. So what we do here is we just interpolate the structure. And you can see that it is moving along the superior orbital plate and then exits through the superior orbital fissure. Once again, you can just track this through the superior orbital fissure, then includes the superior rectus muscle and then the superior contents of the orbit, but just stay above the globe, and then anteriorly as the nerve exits the supraorbital and the supratrochlear foramen laterally. The rest would be included in your primary CTV, so I'm not going to talk about that. It would be different for all cases. The second nerve, we've talked about it before, the foramen rotundum and the V2 and the pterygopalatine fossa and the whole complex associated with it. So maxillary nerve or the V2 nerve needs to be covered in squamous cell carcinomas of skin of the middle face, skin above the maxillary sinus, and the tumors of hard palate when there is a significant perineural invasion. So I would start with the tumors of hard palate. We've already seen, I'll just move the cursor on this foramen and we can see this pathway right here. We'll move up to, you can see this pathway right here on the sagittal section. So you can just place a tracker marker here. I will use a tracker to show you how it can be done. If you know your anatomy, you don't need a tracker, but I'll just place this tracker right here so that you are not lost during the contouring. So what I'll just switch this off and start contouring it from this place where it exits. Rest of it would be included in your primary CTV, so you don't need to worry about that. This level would also be included there. And then you stay just anterior to the pterygoid plates, keep moving spirally. No need to be miser with these structures. There are hardly any structures which can result in toxicity. And as you move spirally, then the whole of the pterygopalatine fossa needs to be contoured. You need to go up till the foramen rotundum. So what you do is, here it is the foramen rotundum, and this should be the last slice, or the slice above it should be the last one. Yes, this one. So foramen rotundum needs to be covered, and then you know that the nerve has entered the middle cranial fossa. And then into the cavernous sinus. So this can be interpolated once again. And we can see that this nerve, as it moves through this canal. Okay, so the second one, second branch and the main branch is the infraorbital nerve, which is the main branch of the maxillary division. And it opens into, it is, V2 needs to be covered in the squamous cell carcinomas. We've spoken about that. It exits through the base of skull and the infraorbital foramen, it lies just below the orbit. So when you are contouring this, you just need to be vigilant that you just stay just beneath the orbit rather than going into the middle of the maxillary sinus. As I move spirally, this whole area needs to be covered along the lateral wall of the maxillary sinus and then into the pterygopalatine fossa, where this nerve is already contoured for another case. We've just done that. Okay, just cover the lateral wall on a couple of slices, the lateral wall of maxillary sinus, and you would be done with this. Okay, so that's all what is needed to be contoured. We've contoured this foramen rotundum and the pterygopalatine fossa before as well, so no need to do that once again. I'll show you this on the other slices, especially this one. Now you can see this one. This is just under the globe, or just under the inferior orbital plate. So this is the region. This is quite a straight nerve from the pterygopalatine fossa through the inferior orbital fissure and then the infraorbital foramen. It's quite straight on the sagittal section. It is a bit curvy on this section, but those things change, and from patient to patient, and the anatomy changes. The third division, the mandibular division, or the V3, needs to be covered in the tumors of the inferior part of the face, the squamous cell carcinomas, and some of oral cavity tumors where there is significant perineural invasion. We are going to talk about this further down into in the next lecture. So once again, one of the most important foramens, the foramen ovale. We've spoken about that. We know where it was, an oval shaped foramen, and the spine behind that, the imprint of the heel. And now we are here, the cursor is right here. The best view for this is the coronal view. You can see that this foramen is placed and beautifully visible on either side of the base of skull. And you can see that there might be some contents which may be visible. You can see this small nerve. There are some structures coming out. So what I'll do is I use a tracking contour and draw some contours for this mandibular division of trigeminal nerve. It has to pass between the medial pterygoid and the lateral pterygoid muscles. And this is just a tracker which you may not use. It's just an option. If you know where the nerve passes, you do not need a tracker at all. So what I'll do is I'll go back to, now the tracker is right here. What I'll do, I'll contour this. When we need to contour it, we just include the whole of the foramen ovale. Just remember, this mandibular division of trigeminal nerve never passes through the cavernous sinus, because immediately after it emanates from the trigeminal or the Gazerian ganglion, it dips down inferiorly and passes through this foramen ovale. So superiorly, this nerve passes through the lateral pterygoid muscle and the tensor villi palatini medially. And as we move inferiorly, this nerve would start passing through in between the lateral pterygoid and the medial pterygoid muscle. I'll go back to the bony anatomy because that is more relevant at this site. So until it touches the mandible, you can see your tracker markers here, which we had drawn on the coronal sections. Even if you see the nerve clearly, just don't draw it. And from here onward, you just take the whole of the mandible. It's not, as soon as the mandibular foramen is visible, you can see this foramen, and you can clearly see this foramen moving anteriorly. I will show you once again. So this is the mandibular foramen. It is moving anteriorly as it, and at this place it exits through the submental foramen. On the other side, we can also see the submental foramen, but you do not include just the foramen, rather the whole of the ipsilateral mandible needs to be included, because this would be in your low risk or the intermediate risk CTV, but the whole of the mandible on that side needs to be included in your CTV. So as I move spirally, I will take, sorry for this. I will include this whole mandible. We can be more neat by using the adaptive tools or whatever tools we have at our disposal. And we take the whole mandible as we have talked about it before. And then we just interpolate the structures. And we'll have our CTV. So this would be our CTV right here. The mandibular foramen, the foramen ovale, and then down into the mandibular canal. Okay, so what I'll do is I will just show you some of the nerves which I had drawn before. We've just drawn the CTVs. What if we have just drawn the nerves? How would they look like? So I'll go to one of the topograms. And if I just switch off the bones and take might be visible on this one. So this is the ophthalmic division of trigeminal nerve. This is the infraorbital nerve. These are the palatine nerves, and this is the main V3 and the inferior alveolar nerve through the mandibular canal. So this is how it would look like, and you can see that this is going through mandible, exiting through the foramen ovale. Very difficult to see, but maybe it can give you some idea. So this was all from my side. The whole idea was to get rid of the agoraphobia that we all suffer from while contouring the nerves and the perineural invasion. We have not spoken about the hypoglossal nerve or the vagus nerve because they are less important and they are contoured less number of times as compared to this trigeminal nerve or the facial nerve, which are very frequently covered. So I would stop here, and I would thank you all for your patient listening.
Thank you very much, Sameed. It was really done very nicely, and I believe the time limit is always a problem, and it's a comprehensive display of V1, 2, and 3. Now I will request Dr. Zeeshan Ahmed Alvi to please come up with your presentation, and after having this presentation, we will go for the question-answer session and definitely the comments from the panelists. Dr. Zeeshan, please.
Thank you very much. So I would be covering, it's a formal presentation. I'll be talking about peri neural invasion in head and neck cancers. As we all know, peri neural invasion is the invasion of nerves, is a common pathological finding in head and neck cancers that is associated with the poor prognosis. When reporting pathology in head and neck cancers, the presence or absence of peri neural invasion should be recorded. And also it should be documented whether the peri neural invasion is reaching up to margin or not, or any large nerve is involved or not. And as we know histologically, there are three connective tissue layers. The innermost is endoneurium, that comprises that covers the individual nerve fibers. Then there is perineurium, that surrounds the nerve fascicles, and then outermost is the epineurium, that is the outer layer that covers the larger nerves. So we can define perineural invasion as the tumor cell invasion in, around, or through peripheral nerves. And there's a difference between perineural invasion and perineural tumor spread. Perineural invasion is a histological diagnosis. Histopathologists report that there is a microscopic invasion in, around, or through the nerves. Whereas PNTS, perineural tumor spread, is a clinical or radiological diagnosis. It depends on symptoms, skin nerve palsies, or on mostly on MRI, we can see that they spread along the nerve root. PNI could be a continuous, contiguous, or a skip lesion, or it can progress in either way, in anterogradely or retrogradely. PNI can be seen with any head and neck cancer, but most commonly they are seen with adenoid cystic carcinoma, cellular carcinomas, mucoepidermoid carcinomas, squamous cell carcinomas, both mucosal as well as cutaneous, and then skin cancers, dysplastic melanoma. Most of the cases do present with perineural invasion. Regarding indication of adjuvant RT, as far as PNI is concerned, in cutaneous squamous cell carcinomas of head and neck, when there is extensive microscopic perineural invasion or there is involvement of a large caliber nerve, then we need to control nerves, as Ms. has already told. Then in aggressive salivary gland tumors, where like adenoid cystic carcinoma or cellular carcinoma, even if there is microscopic PNI, we need to control whole nerve at least to the base of the skull. And then with mucosal squamous cell carcinomas with extensive microscopic perineural invasion, we need to control the involved nerve. In cases of clinical or perineural tumor spread, we need to control nerves at least to the base of skull. Depending upon the anatomical location of the tumor, we need to decide which nerves are to be taken in our contouring. For example, for submandibular glands, lingual nerve, which is a branch of V3, that is mandibular division, we need to contour it, and it enters the base of skull through foramen ovale. Similarly, if there is extensive tumor and there's extraparenchymal spread, hypoglossal nerve is in close vicinity, and we need to control hypoglossal nerve, which enters base of skull through hypoglossal canal. In cases of parotid gland tumors, we need to control the 7th cranial nerve. But if there is extensive tumor, then we may need to cater for the internerve connections, that is the auriculotemporal nerve, which is a branch of V3. In cases of hard palate, we need to contour greater and lesser palatine nerves, which are branches of V2, and they enter the skull through foramen ovale. And there is again interconnection in cases of extensive perineural invasion. There could be interconnection with the branches of facial nerve, which is Vidian nerve and superficial petrosal nerves. For the squamous cell carcinomas of head, skin, forehead, supraorbital nerves can be involved, and they are branches of V1, and they enter through supraorbital fissure. Nasopharynx, again, there are so many nerves which could be involved because of the close proximity of foramen. We need to take foramen ovale, foramen rotundum, and foramen lacerum. And cranial nerves, branches of trigeminal nerves, almost all branches of trigeminal nerves. Similarly, the cavernous sinus, there is cranial 3rd, 4th, or 6th. They need to be taken into our contours. Perineural invasion could be divided into 3 zones based on the extent of invasion. In zone 1, mostly there is invasion up to the point where nerve enters into the base of skulls. For example, it could be from till orbital fissure in V1. For V2, it is foramen rotundum. For V3, it is foramen ovale, and it is celomastoid foramen for facial nerve. From the point of entry in the skull base till their ganglions, it is zone 2. And if the invasion is ahead of ganglion up to base of brainstem, then zone 3 is there. Zone 1 invasion are mostly resectable. Zone 2 are potentially resectable, but they need a lot of technical expertise and a lot of morbidity associated with them. Zone 3 are technically unresectable and practically incurable because of close proximity to very serious organ risks like brainstem. Again, this shows the innervation of skin of face. We already have discussed the V1, V2, and V3. Depending upon the location of skin tumor and presence of perineural invasion, we need to control the nerves. Now I'll be talking about a bit of interconnection between the nerves. There are 3 major interconnections. the Vidian nerve, the auriculotemporal nerve, and quadrant tympani nerves. I'll be discussing them in detail. So in cases of tumors of hard palate, we know that hard palate is supplied by greater and lesser palatine nerves, which are branches of V2, that is maxillary division of trigeminal nerve. From hard palate, the greater and lesser palatine nerves enter the bone through greater and lesser palatine foramina and travel superiorly through greater palatine canal. At the proximal portion of the greater palatine canal, the nerves join pterygopalatine ganglion. The preganglionic fibers of this ganglion, they are Vidian nerves and auriculotemporal, the Vidian nerve and greater superficial petrosal nerves. So here is the point where V2 and facial nerve have interconnections. So we need to be aware of this connection, because if there's extensive perineural invasion or perineural tumor spread, we need to contour both of the nerves till their entry into the skull base. Similarly, in cases of parotid gland, we know that the facial nerve traverses through the parotid gland, but it is the auriculotemporal nerve, which is the branch of mandibular nerve. It provides innervation to the glandular tissue of parotid gland, and that places V3 at risk of perineural invasion as well in cases of facial nerve tumors. Now, what are the indications of coverage of interconnections? In cases of parotid gland tumors, if there is symptoms of involvement of mandibular division, or on histopathology, auriculotemporal nerve is found positive or involved, then we need to contour not only the facial nerve, but the V3. Similarly, in cases of tumors of hard palate or nasopharynx, if there is perineural tumor spread along the V2, then we need to cover the interconnections. In case of submandibular gland, the lingual nerve till foramen, if there is lingual nerve till foramen ovale is involved, then we need to cover the interconnection as well, which is the quadrant tympani branch of the facial nerve. So now coming to the question of how to treat perineural invasions. If there is limited perineural invasion or no named nerve is involved, then adding a generous CTV margins to the section bed to cover local nerve path would be sufficient. In cases of adenoid cystic carcinomas, we need to cover path of the nerve till the base of skull foramina. In case of extensive microscopic perineural invasions, we need to weigh pros and cons of contouring. Mostly in cases of locally advanced D stages and sites like salivary gland tumors, paranasal sinuses, nasopharyngeal carcinoma, or oral cavity, we consider tracing nerve to the skull base foramina. Now coming to the point of what dose perineural invasion should get. In cases of microscopic or focal tumoral perineural invasion, prophylactic doses of 54 to 60 grays are sufficient. If there are positive margin along the nerve, we need to increase dose up to 60 to 66 gray and consider adding concurrent chemotherapy. And in case of DOS disease or perineural tumor spread on imaging, along with adding concurrent chemotherapy, we need to increase the dose from 60 to 70 day. Now I'll be discussing few cases. The first one is the submandibular gland adenoid cystic carcinoma. The target volume covers the tumor bed and the lingular nerve, which is on the middle side of the mandible. And we keep contouring nerve till foramen ovale. At the base of the skull, the dose has been reduced to 54 gray to avoid toxicities. So there was only microscopic extension and we have covered the involved nerve. Now we are discussing the cases where there is extensive perineural tumor spread and their interconnection between the nerves. So this is an MRI that shows that there is a left parotid gland tumor and there is perineural tumor spread of auriculotemporal nerve, which is present medial to mandible. So when contouring, we have contoured the nerve and the parotid gland. They are covered in high-risk CTV, and then the margin to cover give a low-risk CTV. If we go upward, the same case, there is, we can see that there is a perineural tumor spread along facial nerve as well as along auriculotemporal nerve. So both have been contoured. The orange here shows auriculotemporal nerve. And this is stylomastoid foramina, shown by purple color. And then there is high risk CTV includes both of them. And then there's a margin of low risk CTV. The diagram shown as C that shows the anatomy of 7th cranial nerve pathway within temporal bone on axial CT scan. This blue arrow shows mastoid air cells, the green middle ear cavity, black one cochlea. This is the posterior genome, which is shown by purple arrow. It traverses, is just stuck between mastoid air cells and middle ear cavity. Then there is tympanic segment that traverses between middle ear and cochlea. And then there is the canalicular segment that lies in the internal auditory canal. And now this diagram F shows that the course of the facial nerve is contoured with the purple color, and then foramen ovale is contoured by an orange color, and both of them have been included in the low risk CTV. So there are two nerves, auriculotemporal nerve and facial nerve. So this is the interconnection in cases of extensive PNI or perineural tumor spread. We need to cover these connections. So two nerves involved in one in case of parotid gland tumor if there is perineural tumor spread. Now coming to the case of adenoid cystic carcinoma of a hard palate, again here perineural tumor spread is present in this case. This MRI shows the T1 contrast enhanced MRI, the primary tumor is visible, and the same is covered with a margin in the CTV. In the illustration B, we can see that there is perineural tumor spread along V2 in pterygopalatine fossa, which is shown by yellow arrow. Then there is foramen ovale is shown with the red arrow. And then these orange arrows shows interconnecting pathway through Vidian Canal and greater superficial petrosal nerve. So here we have seen that all these have been contoured in purple color, and a margin is applied to make a CTV. To just make you familiar with the normal anatomy on the normal side, the one is showing pterygopalatine fossa, Vidian Canal 2, number 3 is greater superficial petrosal nerve pathway, 4 is foramen ovale, carotid artery petrosal in the petrous bone, then 6 is middle ear cavity, and mastoid ear cell are shown by number 7. So in this image labeled as C, we can see that perineural tumor spread through foramen rotundum, shown by a red arrow, involving cavernous sinus and Meckel's cave. The same has been covered in CTV. Foramen rotundum is shown by this red arrow, and cavernous sinus by yellow. So this is my last case, which is a squamous cell carcinoma, skin of forehead. This is an MRI. This red arrow shows the primary tumor, and the tumor spreads. There's a perineural tumor spread along supraorbital fissure, and then intracranially in the cavernous sinus. And CT is merged with MRI to contour the light purple color shows the visible tumor, and the red color is the CTV. So very close proximity to very critical organ at risks. That would be a difficult case to contour and a lot of toxicity will be expected. So whenever we're doing contouring or treating peri neural invasion, the close proximity to various normal organs at risk pose a serious threat for long-term and late toxicities. In cases of V1 nerves, optic operators and Trigeminal gland are at risk. For V2, retina optic nerves and optic operators through V3, this is the cochlea, temporal bone, brainstem. And in cavernous sinus invasions, there's temporal lobe of brain, then optic operators, pituitary glands are at risk, same with Meckel's cave. And for stylomastoid foramen, where facial of 7 passes, middle ear, effusions, cochlea or mastoiditis are expected. So a thorough knowledge of anatomy and organs at risk in the near vicinity is very important to make a decision to which dose we are going to treat, which toxicities we are going to expect, and how to counsel the patient about it. So in the nutshell, I would like to say that the peri neural invasion is an important pathological finding associated with a poor clinical outcome and morbidity. But appropriately treated and planned radiotherapy can improve local control and reduce the risk of unresectable failures in cases of peri neural invasion and peri neural tumor spread. A careful and vigilant volume delineation is important because there would be a lot of late side effects. So that's all from my side. I thank you all for a patient listening.
Thank you very much, Dr. Zeeshan. It was very nicely illustrated PNIs with the diagrams. And now we will move our show towards the panelist. And I will request Dr. Mohammad Faheem to please have your comments on it. And finally, we will move towards the audience to have to take any questions.
Thank you, Dr. Azhar. Honorable Presidents FARO and PSCO and very, very senior radiation oncologist, Dr. Kelly, Dr. Tati, and my dear colleagues and students. Assalamu alaikum, good afternoon and good evening. To begin with, I would like to thank Colonel Sameed and the team of PSCO to select such a previously less or rarely talked about topic. I think this session should really serve as an eye-opener for the residents and junior oncologists. Peri neural invasion, as far as it is concerned, in head and neck cancers is very important, not only because of its high propensity, but also because of the challenges associated with its treatment. There is very high risk of peri neural invasion in head and neck cancers. It's more than 80% in squamous cell carcinomas, and it's around 95% in adenoid cystic carcinomas. Before the advent of high precision radiotherapy techniques, that is IMRT, VMAT, SBRT, which are within some millimeter accuracy, we were using larger treatment volumes in radiotherapy fields for 2D and 3D CRT. Therefore, the chances of missing neuronal pathways were minimal. All we had to worry about was the lymphatic drainage of the tumor. But now to avoid missing the involved nerves and their pathways, we have to remember and recall not only the nerves in relation to the primary tumor, but also its communication with other nerves and their pathways till their sites of origin in the central nervous system. We now really need to be meticulous and careful more than in the era of conventional radiotherapy techniques. As we all know that peri neural invasion, when positive, it leads to poor prognosis. So we should be able to first detect peri neural invasion. That is possible by assessing signs and symptoms of either sensory or motor impairment, or we can assess it on CT or MRI images and even on PET scan, and of course pathologically after surgery. And then radiotherapy doses, they depend on whether it's microscopic perineural invasion with negative or positive margins, or gross perineural invasion with or without surgery. And I'm sure today's session will really be helpful in bringing attention of radiation oncologists towards taking care of perineural invasion in all patients with head and neck cancers. As if it's missed in radiotherapy volumes, there will definitely be recurrence, which will be too difficult to salvage if it's at the base of skull. And I stop here. This was all from my side. And thank you for letting me a part of this event today. Thank you again.
Thank you very much, Dr. Humera. And rightly said that these new techniques actually require more attention towards these kind of small structures to take into account at the time of contouring. Now I will request Dr. Dini Indriani from Indonesia to please comment about and give your remarks about this chapter and this talk.
Thank you very much, Dr. Azhar Rashid, the honorary FARO. Thank you for the opportunity, and senior radiation oncologist. Thank you. I am Dini. I'm from Palembang. It's in the South Sumatra of Indonesia. So I just want to probably give a prologue of what I'm going to comment or ask. Actually, in Palembang, the development of the radiation center is just come to an advanced technique just in around 2019, 2020. So our experiences in these topics probably not as much as the seniors radiation oncologists here. So probably I'm one of the agoraphobia Dr. Sameed Hussain just mentioned just now. So thank you for the eye-opening lectures. It's a very important, especially for me, to more develop the techniques in my center. So actually, I just want to ask to Dr. Sameed Hussain. So from your lecture, actually from your experiences, so how to set up your CT simulator to have a very good image of the pathways of or the foramen. I mean the position probably and the slices. Do you have the experience to set up your patients to have a good position, to have a good image on your CT scan? Do you always?
The best way which I have seen is to not make a very extended neck, because when you extend the neck too much, the base of the skull just does not remain parallel with the CT scan slice. It just becomes, and the slices won't take all the foramen in one of the slices. They would be in different slices. So when it is not too much extended and it remains parallel to your CT scan plane, more and more of the foramen would be present right in one slice. So this is something that we do differently from the 2D era, is that even while treating for a nasopharyngeal case, we do not extend the neck too much, just keep it neutral, and you would be seeing the things.
Yeah, that's very good idea. Sameed, I would say that one thing very important to note that 1 millimeter slice that will also help you to take a very smaller course of nerves into account. So that will another important part, that you set your protocols accordingly. Very nicely, Dr. Indriani let us know that she is the learner of these new technologies, and with the help of these kind of webinars, we will be able to communicate and to interact with all these kind of amalgam audience and panelists. Now I will request to Dr. Anur Jargal Bezer Galian from Mongolia to please give your comments regarding this webinar.
Yeah, thank you, everyone. I'm Dr. Onajal Baisaklam from Mongolia, and I would like to thank both of the speakers, Dr. Sameed Hussain and Dr. Zeeshan Ahmed Avivi, for their great presentations. And it was a very educational for everyone, I would say. And to be honest, I'm not really a consultant doctor, and to be honest, I'm just a junior doctor that is just practicing for a few years now. And it was a very educational for me. And in Mongolia, it was really not a routine to PNI to see in the pathology as well as in the radiology. And recently, like 2 years ago, we started doing the IMRT, and we are not really experienced, as you can see. So I'm really grateful for it. And I would like to ask the both of the speakers that how about the doses for covering all these nerves like Peri Neural Invasion, because it's very challenging to cover all of these because it's a skull base and we had to obey the tolerance of the OAR. So I would like to ask for I know that it would be like a higher, like the doses would be better, but however, in the 3D, mostly the 3D CRT and sometimes IMRT could not really able to, because we did the CT with the 3D millimeter axial. So I would like to ask for that, and it would be really helpful for us, to be honest, to treat with the patients with the head and neck cancers with the PNI. And yeah, thank you.
That's an interesting question, and thanks for asking. Basically, when we are using VMAT, so that gives you liberty of employing more fields. So and we have a good team of physicists. Mostly they're able to achieve the tolerance doses of ordinary risk. But if the nerve is too close, you have to decide. You have to weigh pros and cons. That what the long toxicity will be, or if you leave the nerve untreated. So if it is just Peri Neural in the histopathology specimen, but there is no gross Peri Neural tumor spread, up to base of skull, you can go for prophylactic dose. But if there is Peri Neural tumor spread, there's no choice. You have to go. And going up to 60 grays, I think you can spare the organ risk as well, because the most critical organ risk here would be brainstem. So up to 54 gray, no issue. We sometimes go even up to 59. But we have to explain the patient that this is the problem. If we don't treat, what's going to happen, and if we treat, what's going to happen. Or if there is gross disease, dose less than 60 is not going to help. But if you're giving a prophylactic dose, even 54 would be sufficient. So in nasopharyngeal cancer, mostly we have seen that I sometimes go up to 59 grade for brainstem, but I have to take my patient in confidence that this is going to happen. So yes, this is tricky, but with the more experience and the more experienced physics team is required to deliver a very good solution. I hope that answers your question.
Yeah, thank you.
Now I'll request to Dr. Lyndall Calais to please come over and to speak about this webinar, please.
Oh, thank you. Both talks were very educational, even for somebody who's been doing it for decades. So thank you very much. Things have changed so rapidly. The quality of the imaging has changed, the ability to treat a thin sliver of 5 millimeters. I mean, it's just wonderful, wonderful. But we work in networks, and we have to work with a pathologist or a pathology team who understand the importance of describing perineural involvement adequately. So we need, the pathologist sees a sample of the tumor, and it's a 5 micrometer sample. It's likely to be, if it shows perineural spread, what we want to know is the nerve diameter. We want to know the location of the nerve within the tumor, the distance from the tumor edge, and the distance from the cut margin. So if it's well within the tumor and they can't see anything near the margin, how important is it? So this needs to be discussed with the pathologist, and we need to see the pictures. In our society, perineural spread is most common with skin cancers, facial, scalp, skin cancers, and I never know how far distal to go. So we've seen proximal tonight, but how much of the cheek do we have to treat? Now, Dr. Zeeshan said you can treat locally around the wound. Yes, but is that always enough? I worry about things like that. And the third thing I want to say is that follow-up with MRI is very, very difficult because the radiation changes the appearance of the nerve for years. So the nerve will highlight for years after it has had a treatment dose like this. So it's very, very difficult to tell the patient what's going on. And it comes down to an assessment of stability. If this year's MRI looks like it did 2 years ago, it's probably okay. But it's an area that we're learning a lot about. And I think tonight's been very, very helpful to all of us. So thank you very much, Dr. Zeeshan and Dr. Sameed. Thank you for your work. Excellent.
That's great, Dr. Kelly. Now I will request the Secretariat to take the questions, please, if the audience has. Over my screen, I didn't see any question. Anyone else?
So that means two things, either everything understood or nothing.
I think everything understood very well.
So that's fine, I guess, that if we don't have any question, so the presentations were self-explanatory on that, and this was a very discrete topic, I guess, and the people, they are a lot of people, they are actually learning on it, and they are improving their learning curve. With all honesty, the Dr. Kelly, what she was telling, that is one of the limitations for the radiation oncologist, that there are so many dependent areas for us, that the radiologist first need to let us know about the real involvement on the imaging, one parameter, and pathologist then, if after operations, they have to get into properly, adequately. So you need to have a very good backup with the pathologist. And along with them, I believe that the surgeons who are working with us, and they need to know about whatever we need actually, that the multidisciplinary input will be a very significant situation with all these kind of very critical areas to improve on these kind of platforms, that if we go for radiotherapy with the modern radiation oncology, modern equipment, we are specifying very small structures, and we are actually trying to treat those small structures with the disease, and simultaneously we are trying to spare our critical organs for the minimizing the late side effects of that patient. And this is the beauty of ongoing modern radiotherapy. And I will again go back to our panelists and all the people involved on this screen. If any question, otherwise I will just close the session.
Can I say one?
Yes, please, Dr. Faheem.
Yes, I just want to appreciate both of our speakers, Sameed and Zeeshan. They have done wonderful work, and they are quite experienced. And this is all the work which they are doing. They are utilizing it as well, and they are running our PSCO school as well. So most of the work is on contouring, and they are doing a wonderful job. Keep carrying on this work.
So thank you very much, Dr. Faheem. So I'll take the chance to thanks to all the audience and the attendees who participated in this webinar. And we'll have next session of this webinar in next month on the platform of FARO, inshallah. Thank you very much. Thanks a lot.
Thank you. Good night, Kelly.
Thank you.
Thank you.
everyone.
Goodbye, everyone.
Thank you.
Speakers.
Thanks a lot. It was very successful webinar, I believe. Our both speakers were very confident, and mashallah, they were very good, expressive, and very discreetly and nicely they presented everything. Dr. Zeeshan and Dr. Sameed. And we are expecting the next webinar again from your side.
Dr. Rashid, can you hear me?
Yeah, please.
Yeah, this is Professor Ramesh Bilimagga from Bangalore, India.
Yeah, doctor.
Wonderful seminar, and the speakers were really good, apt in in giving the information to the youngsters. The one most important point to remember, how accurately we'll have to deal with the head and neck cases and contouring, and very diligently. That is the success of our teamwork in head and neck cancers. The purpose of really starting off FARO is this, exactly is this, how well we can share our information between the countries. And today I feel very proud that we are very successful in that. One of the founder of FARO, so therefore I feel very proud about this. Thank you so much.
That's great. Thank you very much. Thanks a lot for your kind comments.
Dr. Rashid, I think that people are leaving, but may I ask the question about the country experience, because it's like very new to me from the speakers, because do you do the routine MRI for the all head and neck cancer patients, and with the follow-up checkup with the MRI or not? I would like to ask that, because it's not really common to do, except in nasopharyngeal cancers. We do not do the MRI because it's not covered by, not yet covered by the National Health Insurance. So it's difficult for the convince the patients. So we solely based on the CT images. And also the radiologist in Mongolia not routinely check up for the perineural spread. And even after the surgery, the operation, sometimes they just miss the perineural, like they do not report the perineural invasion. So we had to ask them to do it the most of the time. So is it to do like the MRI for all the patients? And
Yes,
thank you.
would like to answer the question. To me, we used to have this MRI with us whenever base of skull is involved, and we do for nasopharyngeal. It is our routine. It's fortunate that we do have this facility over here, and most of the patients, they get it complimentary after paying their initial amount of money, whatever they are paying for the radiation. So this simulation part that contains CT scan and MRI and any other adjunct study which we need, that is involved in it. But I don't know really about the practice of CNH. Dr. Zeeshan, you like to?
Dr. Rashid, most of the patients, they get an MRI.
Oh,
Yeah.
I see. Okay, thank you.
So question is answered?
Yes, yes, because we would like to do the MRI on every patient.
We can have this personal discussion along with that. We can exchange our emails, and it is available on our website as well. And you can just pop up on the Pakistan Society of Clinical Oncology website. All the members are there. Their emails are there, and you can just take that one. Thank you very much. Thank you very much, everybody.
Thank you.
Thank you. Thank you.
Have a good night.
Thank you. Same to you.